in a particular way when we were house surgeons and as PGs. But sir is going to tell you how to take care of patients who are nearing end of life and how to look at this from another perspective. So sir doesn't need any introduction because he has already taken many sessions for you. So it's over to you, sir. Welcome and all.
Thank you, Sunil. Thank you, Raju. Hello, everybody. So this business of palliative care course is almost getting over. I'm glad I had this chance. Thank you, Raju, the opportunity. But is this necessary? Do physical medicine specialists actually treat dying people? Do you? You want to respond on chat? Sharina is the first one that I see. Jijo, also I can see the face right here in front of me. What do you think? Do you treat dying people?
Yes, sir. Almost, we also see such patients.
Or do you treat them so long as you can help them to be functional? And when they are actually dying, do they really get referred to general medicine and then die in intensive care units? Do people die in your ward?
Very less. Very.
Jijo, if you were doing, I mean, not only this sorry, did I interrupt you? No, you're muted, Jijo. I heard you speaking in the beginning. Then you became silent. Jijo?
Yeah, we in our ward we haven't encountered much deaths. When the patients' medical status gets serious, we refer them to internal medicine usually.
And from there to intensive care unit, right?
Yeah.
Hey, Sharina, Jijo, and the others. This is the right thing. I mean, like patients who see you for many years, and eventually when they are dying, they have been dependent on you for a long time. Is there a problem somewhere? Okay, let me share my screen and then we'll talk more about this. Have you heard about Ram Das, who died last year? He's generally considered as spiritual leader above religion. Certainly, when you they talk about religion, you think of some religious person, but he was not. And he was talking about a lot about spirituality, which came to be accepted globally. Unfortunately, he died a few months back. So one of his statements is this: we are all going home to wherever that place is. In this earth, we are walking. We all will die. Essentially, okay. One message that we will take from this is this is not just about them. This is about us. This is about our loved ones. Earlier, you said that dying patients are sent to internal medicine, and I added that from there they go to intensive care units, and that's where they die. 12, there are 11 participants, right? And almost, okay, everybody else apart from me in this audience is young men and women. I'm sorry if I am asking a difficult question. Are you able to think about your own death? again, okay, most people are invisible. I think Jijo and Sharina are the only two visible faces to me. And what I saw was Jijo thinking very deeply, not quite sure whether he is able to think about his own death. I think I saw Sharina nodding yes.
Sir, there are two chat answers. No.
Okay. Uh, Sharina, because I thought I saw you nodding, what was your answer?
Yes, I meant yes. I
You are
can
able
see.
to?
Yes.
Is there anybody else in the group who is able to contemplate one's own death? Raju, there are a lot of people sitting behind you, 4 or 5, all maintaining social distance. If you are thinking about social distance, you are also thinking about COVID. If you are thinking about COVID, you have to be thinking about death. Is there anybody else who is there behind you, Raju, who is able to think about your own death? Not a single reaction. Any reaction? Raju, are you able to think about your own death?
Not yet, sir.
Sunil, are you?
Yes, sir.
Okay. Okay. Sharina, Sunil, and I are in a tiny minority of people in this group who are able to think about one's own death. So, Sharina, now you gave me courage to ask you. Sharina,
Yes, sir.
where would you like to die? I'll give you choices, Sharina. Your own home, a hospital room where your family can be there, and intensive care unit. Understandably, the intensive care unit is the best equipped. Lots of equipment which can keep your systems as near normal as possible.
My room, my home preferably.
Your home.
Yeah.
Sunil, where do you want to die?
Sir, in my room, in my home, in a particular room with all my loved ones, and if possible, by holding the hand of my loved ones, many.
Hey, I mean, just a few months back, just before the Corona episode, I was talking to a group of doctors in Calicut. They were about 150 in the audience. And roughly about 1/3 of people, they were not all young like you. They were young, they were old people also. About 1/3 of the audience, roughly, said they are able to think about their own death. I wished everyone else immortality. And then to the people who were prepared to think about death, I asked, where would you like to die? Almost everybody wanted death at home. But then I asked, but do you give that to your patients? Do you give a choice? Do you facilitate it? And not even one person said yes. Everybody said, well, we send them to ICU. So where do we have a problem there? Sunil was very detailed in his description. He wanted to be in his bed. Sharina wanted to be in her home. You wanted your loved ones. You wanted the death that was possible 2 generations back in my childhood, where death was a social event supported by the medical system. Whereas today, the society and the family are out and you die alone with machines in the ICU. You don't want it yourself, but you do it to patients. This is about all of us. Subconsciously, maybe you are sending patients to general medicine and intensive care units without thinking about it because you don't want to face it. Even when we know that their condition is not curable, the situation is not salvageable. Your patient with paraplegia or quadriplegia dies on a ventilator alone, not able to say a final farewell to the family, not able to get a kiss on the forehead or the cheek. The quality of death index is something that was published in 2015 last. That was the last one, where this international group studied the quality of end of life care. They studied 80 countries. We came among the worst 15. We came 67th. And you may possibly be surprised to see that Malawi, Kenya, etc., many poorer countries are better than us. Uganda is somewhere here, way, way above us. As far as quality of care at the end of life is concerned, we are among the worst. So when you are still thinking about that paradox, you want to die at home. We don't allow patients to die at home. You are still not able to come to grips with that paradox. It is not only what I am saying. The world is saying this. And actually, Times of India, the next day after this was published, carried a headline, "Don't die in India. It is not safe." A British oncologist of Bengali origin, Sankha Mitra, said this. In India, this is about India, the poor die in misery of neglect. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. I don't want to tell you how I would like to die because it will be repetition. It is practically what Sunil said, with the only addition that if I cannot get enough medical support at home, I am willing to accept a hospital room. But for heaven's sake, not that electronic nightmare of ICU for the dying phase. And each one of you, I would ask you to think about it. It is not a comfortable thought today. We were okay with it because we grew up seeing death around us, the elders. But you, most of you will be strange to death in your own families. So please take courage to think about it because it's not only about you. Someday, your loved ones are going to be ill. Do you want them to feel the pain of endotracheal tube and endotracheal suction to the last minute? Do you want the intense loneliness in the end of life? If you do not think about it now, it will be too late. When the time comes, it will be out of your control because they will be automatically in an ICU. This woman is lucky. She was in the poor home at Katela. She at least would get a few drops of water down the throat, whereas the rich man gets that kind of death. And this is something that a Malayali journalist living in Mumbai wrote about her dad's end. Would somebody offer to read it for me? Somebody unmute. Yes, please. What's your name?
Sharina.
No. I thought somebody else, another person raised the arm, but it's okay. Sharina, please read.
My 84-year-old father, my best friend, was enduring raw intuitive medical procedure against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized. But I didn't want to infuriate the doctors in whose hand we had surrendered his body and who had broken down his body into isolated segments. Only they could put back together again, if at all.
You know what these isolated segments are? The cardiologist comes and talks about the intervention. The nephrologist comes and orders the dialysis. And Sindhu's father and Sindhu are totally lost in that maze. So I have been talking about the current problem, the solutions. Dear doctors, when my time comes, please consider my comfort. I know that I will die someday. I cannot live forever. I am willing to go when my time comes. I am not afraid of death, but I am afraid of you. I am afraid of what you may do to me. Please try to keep me as comfortable as always, as possible, physically and emotionally. And if at all possible, please help my family to accept the inevitability of my end. And please, I know you will be busy. You won't have a lot of time. But 1 minute, a touch on the shoulder to my wife or to my children, and just assuring them, we will do our best to keep him as comfortable as possible. That's what I ask of you. If I am to come to acceptance, I should know the diagnosis and prognosis. Sometimes you have already had the sessions on communication. Sometimes thinking that if you tell me the truth, I'll be worried. You may keep the truth from me. That'll give me even more pain. And if when I want to know, you tell me the truth, I'll be ready. And then you ask me, ask me the question that I asked Sunil and I asked Sharina, where do you want to be? Many people are afraid of being at home. Don't take it for granted because the healthcare system cannot reach them. Will I die breathless? Will I die in pain? That will be their concern. If I have said the place, please, I'll come to your hospital, doctor, because I trust you, but keep me in a room, don't take me to ICU. Doctor, if you think it is necessary, please give me a drip, but don't put in a tube into my stomach. You may be tempted to make sure that my nutrition is good. Dear doctors, you can only force food into my stomach. You cannot get into my cells. You cannot give enough ATP in the cells to use that when I am dying. You may give me hypertonic saline, but you cannot improve the sodium potassium pump. So interventions, if I have said I have written my advance directive, I am hoping that I am actually banking very much on Sunil to make sure that I will die in peace. But I may have other thoughts. Everybody may not be like this. I actually had one patient who said, doctor, ventilator or whatever, do anything that you want to. But on the 24th, when my son comes, I should be alive. It is up to that person, and the person's wish is to be respected. I am worried that you may come and keep poking on me because you will find it difficult to find veins, poking all over the place to do my serum sodium. If somebody is dying, it is pointless. It is a horror to see people still being fed somatostatins on the last week of life. What the hell? Why? And routine blood checks avoided unless that is necessary for the management. And intravenous lines generally are to be avoided. They cause phlebitis. They warrant multiple pokes. If possible, avoid them. And you will see that Sunil and team usually manage with subcutaneous fluids. Many medicines can be given rectally. Between rectally and subcutaneously, most medications can be managed, except possibly many antibiotics. But then, would the dying person really need antibiotics is another issue. So, at some point, we should be asking, how is he? Not what is the BP. Again, to repeat something that Raju has said 17 times, when a new nurse comes into our center, not familiar with palliative care, learning, and I ring up at night and ask, how is Mr. So-and-so? They will say his pulse rate is 84, his BP is 100 by 60, his temperature is 102 degrees. We have given this medicine and this medicine. But after a month, if I ask them, they will say, he was a little delirious earlier, but after giving the haloperidol, he is comfortable, he is quiet, he was sleeping till now. His wife is with her. She was crying for some time. When one of us went and sat with her, she is quiet now. That's what they will say. What matters? The BP no longer matters. The position change and skin care is still important even on the last day. We don't want a pressure sore even on the last day because it will cause pain. But it may not necessarily mean 2 hourly change a position. I would use pressure relieving mattresses more than is generally used by the common medical fraternity, not by you, medical fraternity. And try to focus on the comfort. One of the important things that I'll highlight is that even if the person is apparently unconscious, I'll just make an assumption that they are still able to hear. How do you know? They may be able to understand. And especially in people following stroke, we see this repeatedly. Nobody talks to them, but they are unable to speak, they are unable to express anything, and they don't know what's happening. Why not talk to them? Talk about what is happening to the family. It's okay if they cannot understand. What do you lose? It is very important to give support to the family. They have to understand this, understand what's happening. And particularly, we have to remember the children. Children in families where somebody is dying live with a lot of fears and anxieties. Nobody explains anything to them. They grow up with great scars inside them. Manifest as behavioral disorder, learning disorders in school. Children have questions. They need to be answered. And it's important to facilitate any religious right that's important to the family. But here also we will remember the patient's needs comes first. Before taking in the priest for a last communion, make sure that the patient understands the situation, and is ready to receive him. And this may not be easy in intensive care units, but this is absolutely essential. If somebody says the hospital protocol doesn't allow a priest to go in, I would say change the protocol. But this is vitally important. And most importantly, so long as the family wants it and so long as the patient wants it, encourage the family's presence, because this time is a precious time for them. That is helping them with the grieving process. Reduce the incidence of pathological grief. Reduce the incidence of depression during the bereavement phase. And the final goodbyes are very important. Sharina, please read that for me.
Futile and inappropriate artificial life support measures usually cause physical, psychological, and social suffering to patients and families. Palliative care is the humane alternative.
I am not saying that every dying person is to be referred to the palliative care unit, but every doctor treating a dying person has to be familiar with the principles of palliative care. And if we do not offer the ventilator, or if we withdraw the ventilator in a dying person, it is not euthanasia. We do not have a law covering this, but this is the official definition from the statutory body, Indian Council of Medical Research, in 2018. Would you like to read this also?
Euthanasia is the intentional act of killing a terminally ill patient on voluntary request by the direct intervention of a doctor for the purpose of the good of the patient.
You see the word killing? Cruel word, isn't it? But it was important to spell that out. You could have said intentional act of causing death. But euthanasia is about killing with good intention. Good intention. Hey, everybody. So, in the end of life, I am finding that life is very hard. I would like euthanasia. Will you give it to me? Hey, somebody who likes me, please answer. I know that I am dying. It's a question of time. I may die, live for another 3 days. That looks pointless to me. I am in pain. I am in suffering. Please hasten the process. Give me euthanasia now. Who will come forward?
As it is illegal, we may not give.
Okay. Thank you. She is sounding apologetic, isn't it? Sharina. But thank you, Sharina. At least if it becomes legal, I know you will do it for me, but we are not discussing this. This is illegal in the country. If you agree and you give me euthanasia, you are committing murder by the law of the land. We have to abide by the law. The question of whether that is ethically right or wrong is not being discussed today. That's not my point. My point is euthanasia is illegal. We need not discuss it. Sharina?
Passive euthanasia is an obsolete terminology and should be avoided as euthanasia cannot be passive.
What do you think? Many documents, including a recent Supreme Court judgment, use the word passive euthanasia for withdrawal of life support. That's wrong. By international scientific and medical literature, this is wrong. Withdrawal, allowing natural death is not euthanasia. Death is a natural phenomenon. There is a difference between euthanasia and allowing natural death. When I asked to stay in my own room without unnecessary interventions. I was only asking for normal death. Withholding, and this is again from the ICMR document, Sharina.
Withholding or withdrawing a potentially inappropriate treatment in a patient dying with a terminal illness cannot be constituted as an intention to kill.
Does anybody have a question about this? If the patient's heartbeat is maintained on a ventilator, if his blood flow is maintained on a ventilator, and you know by the opinion of concerned doctors, not one person, several, that the person's life is not salvageable, withdrawing the ventilator will mean allowing natural death. That is not euthanasia. It is allowing natural death. Do you have any comment about this? Anybody? I don't see the chats now, so because I have full screen. So please come forward, Raju or Sunil, if there are any chats offered.
No chats yet.
Okay. So, if unfortunately somebody has put me on a ventilator already, I hope when you come in, you will take these measures. You will find out, hey, has he ever expressed intention about what is to be done? And I think my wife will show you the document that I have prepared and signed in presence of witnesses, saying that I don't want prolongation of my life by artificial means. Even if it is not written, it's okay. They will tell you what, they may tell you what I want. 3 physicians will have to make independent evaluation by the ICMR document. And they all say, okay, it's unlikely that his life can be restored to reasonable quality of life. And of course, then you will have to go by the family. Even if I have written the advance directive, you don't want to offend my family. Dead people do not go to court. Living relatives go to court. We don't want to do anything against their wish. It is sheer common sense. The family may not be able to sometimes take decisions immediately. Give them time. They will need some time to take decisions. In the meantime, continue whatever you are doing, or accept decisions for partial support. Like non-invasive ventilation is okay, but nothing else. Like feed him, but don't put him on a ventilator. And this is not the time to bring up the question of cost. If you say anyway the treatment is going to be, if you tell I'm sorry, he's dying, and if you keep him on the ventilator, it's going to cost 50,000 rupees a day, then the family is being emotionally blackmailed into saying yes. Oh, it's a question of money. I don't care. I want my father to live. Put him on a ventilator. They may be forced to say. This is not the question of to build up, bring up money unless they want to talk about it. And a very important point. Hey, everybody, this is very important. Even if we are accepting death, never tell a family member there is nothing more to be done. That is not true. There's no situation where nothing more can be done. Instead say, we will do everything to keep him comfortable. There's a lot of difference. It's very difficult for a family member when you say it's nothing more to be done. And then they will be tempted to take me away to an Ayurvedic physician. Instead say, we will do our best for his welfare to keep him as comfortable as possible. And I'll stop with this. That looks like a complicated diagram. My apologies for that. But start from one end. First and foremost, dear doctors, you have to be sure what your primary duty of care to me is. Your duty of care to me, according to the ICMR, is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. You do not have, by any rule of medical ethics, or by law, you do not have a duty to continue my heartbeat for some more time on an artificial device. Or I am challenging you, show it to me. Where is it said that ethically you have a duty to prolong life at all costs at the expense of suffering in advance incurable illness? So first, we have to accept that our duty of care is not to stretch out the dying process from 2 hours to 2 weeks. And we have to decide what is
Sir, can you
ethically.
adjust your microphone, sir?
We have to, is that better, Raju?
Yes, sir.
We have to decide what is acceptable ethically. My life is my right. I have the right to decide on it. You have to look after my good. You have to avoid harming me. And you have to be fair. But as I said, societal obligations we will have to keep. If you antagonize my family, you could be in trouble. So those societal restrictions they are real. There is no sense in saying that he is the one who matters. It is his autonomy. So I'll defy you. Doesn't make practical sense. And really, though I said don't bring up the money issue at that point of time, the economic factors are important. The cost of treatment is important. And certainly, as we said, that's the final thing. We don't want to do anything illegal. India does not have a law covering end-of-life care, though there is a Supreme Court verdict which is confusing. We do not have a law, and we do not want to do anything illegal like giving euthanasia to somebody. Sorry. I will also suggest for anybody who is willing to think about death, better get your advance directives prepared, not only for you, but also for your family, your parents, your grandparents. But there are a few catches. If I sign a document, you have the ethical duty to follow it. But according to the currently valid Supreme Court judgment, there is a lot of procedure to be followed. They are not practical. Like 2 3-member boards want to be decided by the DMO, district collector, personal visit by a first-class magistrate, etc. This is not practical. But I will remind you of the primary duty of the care, the doctor. The ICMR work task force, including 2 senior lawyers, has advised that if you are sure what your duty of care is, and if the family is agreeable, these conflicts do not appear, the legal issues do not appear. And then you concentrate on my well-being, not on the law, not on artificial life support. Thank you very much, ladies and gentlemen. I'll stop there and take any questions. I am glad we have some time for discussion now.
Thank you, sir. So this is the time for questions. I'm sure there will be many regarding this laws and many other things like withdrawing or withholding. Please ask.
Sir, what was the basis for this Supreme Court judgment? Was it based on any particular case?
Oh, there were many cases over time, but the 2018 judgment followed a litigation filed by a non-government organization called Common Causes. The Common Causes filed a case in the Supreme Court asking asking the court to legislate say that advanced directives should be valid, that artificial life support measures shouldn't be mandatory. Unfortunately, they use the term passive euthanasia for withdrawal life support, and the court continued to use it. That is one confusion. But prior to that, also several people have gone to court asking for several things. Some people ask for euthanasia to be made legal. So this has been an ongoing thing. The 2018 verdict is by a 5-member jury. I mean, 5 judges sat in a bench. Therefore, that will hold valid until the parliament enacts a law. That judgment also said this will stop being valid when the Indian parliament enacts a law.
Anybody else? Any questions from those who are sitting in the echo room?
Who is that?
I'm Dr. Sankita, sir. How are you, sir?
Hi, Sangeeta. I'm well, Sangeeta. Thank you.
Okay, sir. So recently we had a incident where a person with brain death was a candidate for organ donation. So in this case, how can we relate to what today's topic, like end of life? How can we? What is your opinion, sir?
Look, Sangeeta, by the current status, though I mean, there's no law, by though there is no law covering end of life care, there is legislation by the parliament regarding organ donation. A little paradoxical. A law was passed many years back which permits organ donation. Now, there we are talking about brain death. No confusion about that. If the brain is dead, the person is considered legally dead. So, about that, there is no legal confusion. There was some slight confusion regarding, okay, if suppose there is no organ donation and the person is brain dead, what do we do? The Kerala government has given a clarification regarding that. There is no issue, Sangeeta. If you do the tests, both the clinical tests, preferably EEG also, and diagnose brain death, the legal situation wants you to stop the ventilation. But as I said earlier, it is important to keep the family informed, make sure that they understand, because even if the person is brain dead and is so clinically considered dead, if the heartbeat is going on, the family may think you are killing him. So the understanding of the family is important as a practical measure, but brain death is legally considered death.
In case if the family is not willing for it, how do we tackle that situation?
For one thing, Sangeeta, like in any medical field, there will be some situations where we do not have clear answers. But I'll tell you what I would do. I would realize that this family is saying, no, don't stop the ventilation. It must go on. Why are they saying that? Why would they say that, Sangeeta? Because they love the person, or they can't give up the person. They feel, no, my dad cannot die. I will not allow it. Continue the ventilation. Who are you to say that he is dead? The ECG is going on. They are saying it out of love. We have to understand that. What very often happens is, we think the ventilator can be stopped. They say no, continue, and we seem to be on opposite sides. Then the argument starts. If the argument start, I can tell you we have lost the case. We have to understand. And there are other couple of questions. I'll come to that in a moment. But I'm glad we do have some time. A teacher once taught me that we should be what we should do as if it was a tennis game. What happens very often when the family is not aligning with your advice is that they serve, you serve, they return, and the game of tennis goes on, arguments go on. What this teacher told me is, jump over the net. Tell the family, I see you are suffering a lot. I see that you love your dad so very much. We are here to help you. Tell me what's going on through your mind. What was going on in your mind when I said your father is considered brain dead? And they will then talk. It may take some time. That time is essential. If we needed a tracheostomy, you will find the time, Sangeeta. Similarly, investing that 1 hour in this is important. They will talk about how the dad was everything for them, etc., etc., etc. They will cry. And you will acknowledge their suffering. Once they feel that you are their friend and not an enemy, then they will say, no, doctor, you can't stop the ventilator. And you may say, I see what you are saying. We will continue whatever we are doing. But I want you to go back and think about it. And maybe tomorrow morning, please come back and see me. We have to give them time. We have to listen to them. And tomorrow morning when they come, again you are making them talk. And at some point, they will allow us to exchange the information. They will allow you to talk. Or they may ask themselves, doctor, what do you think is really happening? Why is it that his heart is going on beating? And then that may be the time for more explanations. Understandably, this takes time. But here time is needed. Even when you go to a restaurant, when you are given a menu, you take 10 minutes to decide what to order. The family cannot possibly take such a vital decision over 10 minutes. They will need a day, and that's only fair. If we have, as we should, if we have initiated a discussion early, then things are easier. Asha asks, how to handle young adults or children with terminal illness? Asha, it is easy. What is difficult is to handle the conversation with the family. Children very often are much more realistic than us. They ask straight questions. They accept straight answers. They may ask things like, will I go to heaven or hell? And you may have to listen to that question. Actually, a child asked me that question. Will God not punish me when I die? That was his own fear about death. Will God, he has leukemia. Will God not punish me? I asked him, Why, son? Why do you think God will punish you? Because I have done several wrong things. I pulled my sister's hair sometimes, several times. I used to quarrel with her. I once lied to my mother. So will God not punish me? And I asked the boy, hey, what do you think? Is God a good person or a bad person? He said, God is a good person. Do you think a good person will punish small kids for small things like that? And he said, no, I don't think so. That's the way they react. Unlike adults, they are frank. Once they trust us, they are frank. They were open. They receive truth very well. Elizabeth Kubler-Ross tells a story where a child's leukemia treatment was going on and on and on. And the family went on pushing more chemotherapy into them. One doctor will say no more, and they will find another oncologist to give one more course. Finally, they had this conversation. The mother reluctantly allowed them to talk to the child, allowed Dr. Kubler-Ross to talk to the child and find out what his fears and anxieties, where the child asked everything. And then the child said, Dr. Rose, I want you to stay here for 10 more minutes. Doctor actually wanted to go. She had plenty of work, but she stayed. And the boy said, Mother, I know I am dying. I don't want to get those medicines anymore. Do you understand? And he forced the mother to accept that decision. The child did. And then he said, Dr. Rose, just 5 minutes more. And he called his younger brother, the child, and said, I want my dad and mom to hear this. I won't be able to ride my bicycle anymore. From today, you must have it. See what is happening? The boy accepted. And Dr. Rose, my mother has agreed. Now you can go. So I find that story very touching. Legacy is very important. That child had to leave that legacy to the child. My bicycle, which I will never ride again. But children are much more courageous than adults, very often in accepting. But you will need a lot of time spent with the family to persuade the parents to accept it. Dr. Jiju asks, does Pallium India take the opinion of patients regarding their end-of-life care as a routine? Where, Jiju, this can be asked only when we have discussed the diagnosis and prognosis. Very unfortunately, we get too many patients in the last few days of life where we do not get the opportunity. But when we start seeing them early, when we have the luxury of talking to the family also, this indeed is what we do. Even at this moment, we have a patient in the intensive care unit where the rest of the family has agreed. The wife has not been told. The daughters have not allowed the team to talk to the mother, and therefore there is still a gap. So these are questions that we overcome. So the procedure is this. First the discussion about diagnosis, then about prognosis, then about the patient's wishes, then with the family, making that conversation possible. Sometimes the family will say, no, don't tell him. And if they keep on doing it, this is what Dr. Arjun did day before yesterday with that patient. Get permission for an exploration. Okay, I will not tell him anything today, but let us find out what their fears and anxieties are. That's one step. So we explore, and then the person will say very often, oh, I know, doctor, they think I don't know, but I know I am dying. Very often patients know, and they say, and then you can go back to the family and say, look, this is what he says. Maybe we now need a joint discussion with you. Dr. Mung, how do I know? Sorry, I can't pronounce your name correctly. Dr. Mung, your question is passive euthanasia? Oh, we have 4 minutes more. Jijo, I am sorry, I am moving on too fast, I know, but I thought the last 3 minutes I must spend on this question. Is passive euthanasia only allowed for brain death patients? Okay, I'm glad you asked the question. Gives me the chance to explain once more. Withdrawal of futile artificial life support is not passive euthanasia. Passive euthanasia is not legal in India. Though the Supreme Court uses that word, passive euthanasia is still causing death. We are only allowing natural death. Now, today, brain death patients is legally considered dead. Somebody who is brain dead is dead. And the law allows for withdrawal of life support without any problem. But there is no law concerning persistent vegetative stage. So that's where we need to find out the patient's wishes. If they had expressed it, where we talk to the family and take a joint agreement to stop further aggressive measures. We generally continue whatever is being done, but they do not escalate treatment like ventilation or dialysis. Dr. Mung, have you understood my answer, and do you have any further question?
Yeah, sir, I understand. No further questions, sir. Thank
Okay,
you.
thanks. Thanks, Dr. Mung. Dr. Mung, how do you pronounce your second name? Gite?
Guite, sir.
Guite. Okay, thank you.
Yes, sir.
I have 2 minutes more for a final question if there is anything. Sunil, are you there?
Yes, sir.
Sunil,
Yes.
this is a very busy evening for me. So can I leave the case discussion to you and sign out?
Okay, sir.
Everybody, will you allow me? Because there are a few pressing things. Dr. Sunil Kumar will be staying on for the case presentation to continue. Raju, I have your permission, I hope. Thank you very much. Thank you for the interaction. And Sharina, thank you for doing some other reading for me. Bye-bye, everybody. All the best to you all, because the courses will be finishing next week and we may not be meeting like this again. All the best to you all, and thank you.
Thank you, sir.
Thank you, sir.
Dr. Sunil, can we move on to the case presentation?
Yes, please.
Dr. Sinju?
Can you hear me?
Yes, ma'am, we can.
I will start the case presentation. Good evening to all. Next slide, please. I am going to present a case about a 26-year-old male with the diagnosis of spinal cord injury, which is non-traumatic paraplegia with neurological level of injury T5, neurogenic bowel and bladder dysfunction, and a sacral pressure sore of grade 4. He was a known case of testicular carcinoma, surgically treated and completed radiotherapy, currently receiving chemotherapy with spinal and lung metastasis, HIV positive status on antiretroviral therapy. His presenting complaints to our department was weakness of his both lower limbs for the past 9 months, loss of sensation in both lower limbs for the past 9 months, and loss of bowel and bladder control and sensation for the past 5 months, ulcer over his lower back for the past 2 months. History of present illness. The patient was apparently normal 1.5 years back when he noticed pain and swelling in his scrotum, for which he consulted a surgeon in GH General Hospital, Trivandrum, and following that investigation done, and he was advised surgery for that swelling. And after the surgery, the sample was sent for histopathological examination, which he received the result after 1 month, and they asked him to consult at our regional cancer center, Trivandrum, where he was further investigated, and they said he had cancerous lesions in abdomen also, probably metastasis, and was planned for receiving chemotherapy and radiotherapy. But before, since considering his young age, in view of preserving his future fertile needs, he was referred to SAT Trivandrum before starting any treatment, chemotherapy or radiotherapy, where he was investigated, and while there, during that investigations, he that revealed retropositive status, and he was started on antiretroviral treatment since he is receiving cancer treatment that time, and he was referred back to Regional Cancer Center, Trivandrum. And after that, he completed 15 cycles of radiotherapy and 5 cycles of chemotherapy. And while receiving that the therapy, he developed a weakness of his both lower limbs, which is associated with loss of sensation, and it is also gradually progressive. So he was sent for orthopedic opinion, and where relevant investigation and imaging was done, and he was advised for to take complete bed rest, and a spinal brace was prescribed there. And the loss of power and sensation was progressive, and he could not, at present, he could not move his lower limbs at all. And he also has loss of bowel and bladder sensation, and for the past 5 months, for which he was catheterized and is on continuous bladder drainage, and for bowel he is on diapers. As I said, the weakness gradually progressed, and now there is complete loss of movement in his both lower limbs, and he developed a pressure ulcer over his lower back 2 months back, which slowly increased in size. And he approached PMR department for pressure sore management. Past history, he was receiving the antiretroviral therapy since 1 year, and no other significant illness in the past. Personal history, his bowel habits is he has no sensation, and it is incontinent, and currently using diapers. And his for bladder, he is on continuous bladder drainage. His sleep is disturbed. He has irregular chart. He sleeps less at night and more during the daytime. His diet and appetite is reduced, and no addictions. No other significant illness in the family. In case of social history, the patient has studied up to 9th standard, and he was a manual laborer prior to this illness, and he has no other occasional training. He is unmarried and living with his mother and grandmother. They live in a rented house. He was a sole breadwinner of the family, and currently their financial support is from their maternal uncle. On examination, his vitals, pulse was 72 per minute, BP 110/70, respiratory rate 17. He is febrile, and saturation is 98% at room air. General examination, he is poorly built and nourished, and pallor is present. No icterus, cyanosis, clubbing or edema. Sacral pressure sore is present, which is of 8 × 5 centimeter with a slab. Next. CNS examination, his higher mental functions. He is in depressed mood, conscious oriented, cranial nerves are normal, bilateral upper limb with a normal tone and power 5, lower limb, whereas it is the tone is reduced, hypotonia, and grade 0 by 0 power. Sensation, the light touch and pinprick were absent from T6. Deep tendon reflexes is normal in upper limb and absent in lower limb. Plantar bilateral mute, and bulbocavernous reflex is absent. In case of musculoskeletal system, he has bilateral TA tightness, and both the ankles are stretchable up to neutral. Respiratory system, air entry bilaterally equal and no added zone. His single breath count is 20 and chest expansion 2 centimeter. CVS S1, S2 present, no murmurs. GAT soft, non-tender, no organomegaly. Bowel sounds present. genitourinary system, external genitalia normal. His present functional status, he does not have any bed mobility. He is dependent on supine to sit and lacks any sitting balance. He is dependent in all his trances and all self-care activities. The significant investigation, his MRI spine, which was taken on 13th of May, showed enhancing lesion in T1 to T4 vertebrae with adjacent soft tissue causing spinal canal narrowing, cord compression, and cord edema. Lesions is also seen in other vertebral bodies. Nodular lung lesion is seen, probably metastasis. And the treatment plans are he is placed in spinal cord injury rehab program. Pressure sore management started where daily dressings were done. Physiotherapy was started. He was placed in graded tiltabling and mobilization exercise given. Self-care activity training was given with modifications. Bladder assessment and rehabilitation. Bowel program was started. His proposed ambulation mode is wheelchair ambulation. He is currently receiving antibiotics for his pressure sore, laxatives, antiretroviral therapy, chemotherapy, and AFO for his tender Achilles tightness. And the chemotherapy he is receiving etoposide 50 milligram once daily and TLE regimen for antiretroviral therapy. Psychosocial aspects, he used to spend time with friends for recreation before the illness, and he has lost his job following the illness. His mother and grandmother are dependent on him. The patient is depressed and refuses to communicate with anyone. His mother cries often and spends her time in prayers. She blames the surgery for the retroviral infection. Patient was a religious person but now shows no interest in any matter. His social circle has dwindled. He said he is reluctant in speaking with anyone. And the main concern is limited life expectancy of the patient, making the patient complain with the treatment process, counseling of his mother, training the mother in the patient care. Summary of the case: a 26-year-old male who went underwent a surgery for a scrotal swelling, which was revealed to be a testicular carcinoma, and further investigations showed spine and lung metastasis. He was also detected to be retropositive incidentally and started an ART following. He received radiotherapy and chemotherapy. While on the therapy, he developed paraplegia and associated loss of bowel and bladder sensation and was catheterized and put on diapers. He developed pressure ulcer as a complication 2 months back. At present, he lacks bed mobility, dependent on transfers, self-care activities, and he seems to be depressed and lost interest in everything. Discussion points to be discussed: if the patient refuses further chemotherapy, how to handle that, challenges anticipated in the palliative care for retropositive patient and how to tackle them, how to provide solace for the patient and also his mother, how can the community contribute to the his end of life care. Thank you.
Okay, thank you, Dr. Sincho. The first question is regarding if the patient refuses further chemotherapy, how to handle it. So anybody in this group has any thoughts on this? Patient doesn't want further chemotherapy. So what to do?
I think we should ask him why he's refusing the treatment.
Mm.
Is it the cost or some other reason? Try to solve those reasons.
Okay, that's very important. Any other points?
He might be angry at the healthcare system since he got HIV infection after the surgery.
He believes like that?
Yes, he believes like that. His family believes that, and there is a history of blood transfusion, but I am not sure since the records are not available.
So as per them, when they went to the GH before the surgery, the investigations were done. So that time they were negative. And so after the surgery, they became positive. So they think it's because of the blood transfusion that they received that have turned him positive.
But still, that's not the reason for refusing chemotherapy, isn't it? Uh, is there anything else? We don't know why he is refusing chemotherapy. Like Jijo told, we have to find out what are the causes. We have to actually talk to him. And you already told that the patient is very reluctant to speak. His sleep is disturbed, and by considering these two features, probably this patient we have to assess for clinical depression. So he might be in clinical depression. So I think we need some help from psychiatric colleagues and ask many other questions, which how is his mood? Uh, is he enjoying anything that he was enjoyed previously? Is there any ideas of suicide? All those questions should be asked. And sometimes this patient might be in depression. So if he is in clinical depression, that needs to be treated so that he may further agree to chemotherapy. But suppose the patient is in very uh, very good mental condition, and he knows that he is HIV positive, and if he is not taken chemotherapy, his disease will progress and he is going to die. Now, you think of a young man, 26-year-old, who is unable to move. Suppose if we were in that condition, uh, what would we opt for? Uh, will we opt for continuing chemotherapy, or just chemotherapy and opt for some comfort care? What's your opinion?
Yeah, seeing it is futile, he may refuse further treatment.
Uh, so a patient who's 26-year-old who was very much mobile suddenly became bedridden, is dependent for others for all the activities. And probably he might be knowing that he has scrotal tumor which has metastasized to lung, and his life is also limited. In addition, he has HIV. So probably he might be thinking that okay, I have all these problems, and with this type of advanced malignancy, I don't want to ruin my family by treating my disease. That may be his thought. And what about his quality of life? What do you think?
Can be improved.
Can be improved?
It can be improved from the present state, definitely. Yeah.
Okay.
The
So will he be able to walk? What do you think?
No, the prognosis is not good on that.
Okay. So suppose we are the patient. What does we want? What do we want? If I am the patient, I would like to walk. That's what I consider. That's what I consider my as my quality of life. But here the patient is bedridden. So maybe if I were in his position, I may also not agree to take chemotherapy, because I don't want the reduced quality of life because of all this. But if I'm in depression, please treat me, so that my thoughts may become different. So that's what I think uh, regarding the first question. If the patient is not in clinical depression, and if he knows about the disease prognosis, then he knows that he is going to die. So it is his wish that he will not take chemotherapy. So in such situation, we should respect the patient. Considering the principle of autonomy, uh, if he has all the information regarding the disease, we should respect the wish. But if he has depression, I think we have to treat him, and then again ask him, now what do you feel? Maybe after 4 to 6 weeks of antidepressant therapy, he may come out of depression. Anybody else want to comment on this? Okay, so what are the challenges anticipated in palliative care for a retropositive patient, and how to tackle them? Okay, I think a few of you has come for posting in palliative care. So what do you think are the challenges from a palliative care point of view?
One would be handling the wound,
Mm-hmm.
then changing
Yeah.
his catheter. All this
Mm-hmm.
would need extra protection.
Yeah.
There will be a social stigma in case.
Yeah. Yeah, it's true that when somebody has HIV, there will be uh, uh, we actually we for all patients we have to take universal precaution, but we usually don't take that. But when we know that somebody has some other infectious disease, we then take extra precautions. So then everybody knows that that patient has some problem. Okay. So as Jijo told, caring for the patient, wound and catheter change, and for such purposes, we may require extra care, and I think we already have a very few HIV patients, and we are taking care of them. But till now, we haven't come across such challenges. They are not on catheter or don't have wound. But I think we have to train our health force to tackle these problems. Social stigma, I don't think there is social stigma, but as healthcare workers, we usually interact with these people just like any other normal patients. So from our point of view, we don't have stigma towards such patients. And anything more to add on this? For anybody?
Have you had personal experiences handling such?
Yeah. Right now we have one patient, but he is not bedridden. Uh,
Whether
he's
they have any special precautions or needs that we have anticipated?
uh, actually we don't usually take any extra precautions for them. He doesn't have any wound or catheter. He comes here like a normal person. We assess him. We do all the normal things that we do for any other patient, and he's also having lymphoma malignancy. He's taking chemotherapy, and he is also on antiretroviral therapy. He has pain, so we are treating him like any other normal person. So no extra precautions, but as you told, when we do the catheterization or the wound care, we have to be careful that the body fluids should not come in contact with us. So that's what we need to take care of. Okay. Uh, how to provide solace for the patient and his mother? What would you do? Any comments?
He seems to be crying. If we ask, he doesn't say anything. Even he, when I asked him for the history and asking for the details, he seemed to be crying. I don't know how to counsel him. I don't know.
Yeah, actually, I think most probably there were hmm, there were no much people who has sat with him and had him about his problems. You just try to explore, but I think that will take time to make a rapport with this type of patients. So I think it is important to make a rapport with him and then he will open up and he will talk about more about his problems. Maybe he might be, how old is his mother?
55 something, sir.
55. Okay. So I think one of the important thing in this would be, does the mother know that he is HIV positive?
Yes, sir. Yes, sir. She knows. She
She
believes
knows.
she got it after the surgery.
Okay.
It is very difficult to communicate with her. Also, she only answers the question we ask, very specific and that too very restricted, and she doesn't share her concern even if we spend some time communicating with her. So I don't know what to do.
Yeah, I think the reason behind this would be, wherever they go for the problems of HIV or for the cancer, they might have got bad experience, and this might be the reason for not opening up, both mother as well as the patient. So I think we need to make continuous effort to make a relationship. That's the only way we can talk to both and give some comfort for them. So I know that you have tried, but there are some patients like this. Even some patients will be angry with us to start with. We have experience like that, and but uh, when they visit us for a few times, they will become very friendly, and then that's the time that we have rapport with them, and they will speak very freely. So we have many experience like that. So I would advise you to continue to talk to both of them, and they will allow you to enter into them and to find out the problems and to give support for both of them. So how can community contribute to end of life care? Okay, so that's a very interesting question, and I think most of them we discussed during the class. But for the community, what what are a few things that need to be there for the community to be supportive for the end of life.
They should have the knowledge, and they should know about the patient and the details, I think.
Yeah.
They should be willing to help him also.
Okay. So the community always or as of now our social culture is a death denying culture. Okay, so we don't want anybody to die. That attitude has to be changed. So when we train our volunteers in the community, we train them, or one of the topic would be end of life, how to take care of patients who are nearing end of life. So they know that treating him in an ICU or in a hospital is not going to do any good for the patient. So that should be the first thing that the community should know. But at the same time, if needed, there should be some medical help that should go that should be available to the patient. So there are some there are palliative care centers who can provide end of life care, but limitation would be they will not be able to go to every day to this patient and also to help with the community. But these volunteers have knowledge on many aspects of end of life care, but they won't do any medical things. For example, suppose many families have a concern that when the patient is near end of life, they will have rattling sound. Okay, so which is known as death rattle. When they take breath, there will be a rattling sound coming out. So the family will think that the patient is choking. But what we have to understand that, or the volunteer has the knowledge that it is not the choking, it is because the patient is unable to swallow the saliva which is formed because the reflexes are lost during end of life, and they will just uh, change him to a lateral position so that the collected saliva will ooze out, and he will have normal respiration. uh, so after death, there will be Riles tube or catheter. So they would also know how to remove this. They need not know how to put this because that is medical procedure and we should not tell them. But they should know how to remove them, because there are many patients who has told us that they are waiting for the catheter to be removed, maybe for a day, because they doesn't get a nurse or medical help. So the community as such will be able to support the end of life if they are trained. But in the older times, uh, the people in the community will come to the dying patient's house, and they will be sitting without doing anything, but they will be supporting the family, and they will be chanting Ramayana or mantras, etc., etc. So that has now changed to the death denying culture. So the community will be able to do much for the patient who is end of life. They will be able to give psychological support for the family, and they will be able to help medically for the patient also. So community has a very good role in not only in palliative in end of life care. Okay.
Thank you, sir.
So I think we time is 4:30. We have to finish
Yes,
this.
sir.
So Dalashmi, I think we can close this session. And
Yes, sir.
thank you
Thank you,
for
sir.
that was an excellent presentation, and thank you
Thank you,
all for
sir.
your active participation. So it's over to you, Rajlakshmi.